Welcome everyone to Advanced Care Planning and ICU Perspective. We'd like to acknowledge that Hospice Waterloo Region is based on the ancestral and traditional territories of the Anishinaabe, the Haudenosaunee, and the Attawandaron Neutral people. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging them reminds us of our important connection and responsibility for the stewardship of this land, where we live, we learn, and we work. So thank you for being here. So today, our session is being facilitated by our wonderful advanced care planning team. We have Lynn, we have Deb, we have Patty, we have Susan, we have Wanda somewhere in this group, and we have Dana and myself from Hospice Waterloo Region. I'm the community engagement lead. So we're very excited about this session, and I just want to make a couple of points before we get started. I'm doing the tech part. My children would laugh at that, but that's the truth. We ask you to mute your phones. The way we're going to run this session, the first part of it is our team is going to ask very specific questions of the three panelists, which Lynn will introduce in a second. And then we're going to open it up for a very large chunk, we hope, of time for you to ask your questions. So we ask you to stay muted for those question parts with the team. But you can put your questions or your name in the chat, and our team, right, we've designated Wanda and Patty to keep an eye on the chat. And when we open up that question period, we'll start with the questions in the chat. And you can also just put your name in the chat if you're not comfortable doing all that typing, and we'll call on the names. We'll do the chat first, and then we'll open it up so you can just raise your hand, or in the bottom corner, there's a little reaction button. You can choose the hand signal, and we will work through those in order. Okay. That's the chat part. I do have a poll at the end that I'm going to ask for your feedback. So I hope that you can stay long enough to just take a couple of minutes to fill out that feedback part. And the last thing I want to mention to you before I turn it over to Lynn is that we find with our sessions that you really need to be wearing two hats. It's a natural thing. You're sitting and you're listening and you're thinking about yourself. This is the kind of information I need to be sharing. This is what I need to think about in terms of who I choose as my substitute decision maker. But you're also wearing the hat of very likely being asked to be someone else's substitute decision maker. So we ask you to come at this information with your ears and your visuals with those two hats on. So on that note, I'm going to turn it over to Lynn.
Thanks, Shelley. My name is Lynn Weimer. I worked for 39 years as a registered nurse. The last 35 of those years were spent in intensive care units. And it would be just absolutely heartbreaking to see what these families went through trying to make decisions on their loved one's behalf. If we were fortunate enough that the patient could still speak to us, we could ask them directly, what do you want? What treatment will you accept? What treatment will you not accept? And they would give us very clear answers usually. Sorry, Shelley. You're muted, Shelley.
Just asking that there's some noise in the background, so can people please ensure that they're muted? Thanks. Most cases, when we would admit a patient, they were unable to communicate with the staff to give consent for treatment. So we had to go to their substitute decision makers, which was usually family, it may be friends. We would go out to the waiting room and talk to this group of family members, and they would be the deer in the headlights. They would look at us and say, you want us to decide what? We've never talked about this. We don't know what mom's wishes are. We have no idea what to say to these things that you're asking us. It was heartbreaking, so heartbreaking to watch that. So once I retired, I was fortunate enough to fall into, actually when I was working, the joke was that when I retire, I'm going out and teaching the whole public how to figure out what to do ahead of time. And then this opportunity of volunteering with hospice just fell into my lap, and it was just the most perfect fit. I'm so happy to be able to get out and get this information out to people. Most of you, if you ever are dealing with a critical illness, you think about the doctors, the nurses, the surgeries, the treatments, the medications. What you don't think about is that a physiotherapist is going to help you reach your potential goals, or tell you that you're not able to reach what you would like as your goals.
A social worker is going to come and help you cope with some of the issues that you deal with, you and your family will deal with around all these issues. So the three guests we've chosen today are two physiotherapists and a social worker who I used to work with, all three of these ladies. And they are the people that will be able to help you answer your questions about what your goals are. Stop and think about what is valuable to you in your life. Should you have a critical illness? What do you need? What are your must-haves to carry on and get to the goals and the best quality of life you possibly can? So with that, I'm going to turn over and ask these three ladies to introduce themselves. So Katie, we'll start with you.
Okay, thank you, Lynn. I think my connection is poor. I can't see anyone. So just if someone wants to interject, just speak up because I can't see any cues. So my name is Katie Garner. I'm a social worker at Grand River Hospital. I've been a hospital social worker for about 13 and a half years. The majority of my work has been in the intensive care unit. And talking about your advanced care planning is important from that perspective, from an ICU social worker perspective, is because I often, a big part of my role is supporting or sorting out with families who is the decision maker. So when you've chosen someone that you know and trust, it makes it much easier. Whereas if we don't have a clear power of attorney, we have to go down a hierarchy. And it's great if it's a spouse that you love and know and trust and know your wishes, but it gets a bit more murky if you've got multiple children, they don't get along, they have differing opinions of what should happen, or maybe there are no children, there's just some cousins or nieces and nephews, and whose role is it? It can get really sticky. And then of course, the hardest part, as Lynn was sort of alluding to, I'm often in the family meetings with the doctors and the team who are explaining the patient's health. And then I sit with the families afterwards who are in that position to have to decide, what do we do? And it's a terrible position to be in, often, I'll say. Sometimes we feel good when we know we've been appointed by someone. It kind of feels good, like they trust me, they love me. But when you're in that situation, you don't always feel that way. And so a lot of these folks, as Lynn said, they just do not know what that person would want. And really, they don't even want to know what they think. They just think, I just want to do right by my loved one. And they have to live with the decision for the rest of their life. So the families, it's not any easier when the families do know what the person wants, but when they're able to say, I know dad or mom would never want this, we need to stop. Yes, it's hard, just as hard for them to do that, but there's a sense of peace. And what I think about that is it's a gift you've given your family to tell them that, because you relieve them of such guilt and they have a better sense of what you would want. So I really think talking to your family about advanced care planning is such a gift. It's not easy to bring it up. When do you bring it up? But it's such a gift to do it. So that's why I'm passionate about it.
Yeah, thanks, Katie. That just wraps it up in a great nutshell. Lisa, let's go to you next.
Sure. Hi, thanks for inviting me. I really appreciate this because I find this such an important conversation. So like Katie, I've worked for more than 13 years, most of which was in the ICU, and just recently shifted to another position with similar types of patients. And actually, some of them are ones that I have treated in the ICU that now live in this other facility. But most people think physio role is simply just getting you better, just working hard, working your muscles, trying to get you back to the function that you were before. But it's not that simple, as particularly in the ICU. We're looking at such a big picture whenever we see somebody in the ICU. We're thinking about what illness they're currently dealing with, what illnesses they've had before, what their function looked like before, and then helping the team and the family and everyone determine what the actual outcomes will be after this critical illness. Whether they are going to get back to what they used to be, highly unlikely. Nobody ends up back where they used to be after any illness. So a lot of our role, especially in the ICU, is actually speaking to families and helping them with determining, when I say that they're likely going to get back to walking at best, or maybe they're at best being able to stand and get in a wheelchair. when we're talking with them, we're able to help them think about those, what would have mom, dad, brother, sister accepted as an okay quality of life for them. And with that, we're also thinking about, will they be okay with what that road looks like to even get there? It's not just about what they would want to be like. It is a really hard road. It is a very uncomfortable road. And it is something that feels very trying, both for the patient and for the family. And there is a lot of work, but not just physically. There is a lot of emotional work from both ends that would go through, that you have to endure in that rehabilitation process. And you may not even obtain something that's an appropriate quality of life, an acceptable quality of life. So I find these conversations really important that people can have before they come in to talk about, thinking about what your function looks like now, and what, even over the last 5 years, has it already started to decline? Is there been changes that are sometimes hard to see until somebody's having this conversation with you, and you can realize that, you know what, dad actually hasn't been walking as much as he was previously. And, he was walking 2 miles before, now it's, 100 meters, and really considering what trajectory they were on before they even had this acute illness, and then using that to move forward. But just having the conversation and knowing what was important to that particular person, because as Katie said, we're often asking you not just making decisions, but what would that person have wanted? What would they say in those situations? Would they be willing to go through all of this very challenging work to get to something that is not what they were before? So I find that having this conversation, thinking about a broader picture other than just that medical information, is so helpful. And I just really appreciate having this opportunity to discuss it here. Thank you.
Thanks, Lisa. That you've covered so many things that most of us never think about. You just think about, I'm sick, I'm going to get better. What's next? You don't think about how hard it is to get better. Brenda, let's hear your thoughts.
So I'm Brenda Henderson. I'm, you mentioned, a physiotherapist. I've worked at Grand River Hospital for 32 years. I'm the old broad of the group. So I started my career working in rehab. So a lot of experience with stroke, spinal cord, head injury, worked in medicine, worked in oncology, a whole lot of areas. And about 2007, I went to ICU because nobody else would work there and the job was empty. And I took my neuro approach to physio to the ICU, which was pretty shocking to actually a lot of the staff there. Because when I arrived in ICU, how the measure of success was determined was whether the person survived ICU and made it to the unit. But I had treated lots and lots of people on medicine and other units who had survived ICU and were none too pleased that they'd actually survived. Actually, we're pretty darn pissed that we'd done something to them they didn't want done to them and actually survived to a level of care that they never wanted in the first place. So I spent a lot of time in ICU really doing some detective work about what was quality of life of this person, what was their actual functionality, because that actually never came into the conversation in rounds prior to that. They simply talked about what was the premorbid disease status and what were their numbers. Doctors are big on numbers. What were their vent numbers? What were their lab numbers? What did their medical imaging look like? All the data. But nobody had ever actually stopped to ask the question about what did this person's life look like beforehand? And some of the science in ICU that we do know is the functional status of the patient prior to going to ICU is the single greatest indicator of whether that person will or will not survive intensive care. So we were making a lot of decisions without having actually the best information. And the statistics are actually pretty abysmal. Less than 10% of people who survive ICU or go to ICU survive to an acceptable quality of life. So it's a very expensive, aggressive, invasive treatment plan with a very low rate of success from a quality of life perspective. And I always think my main focus is, how do people want to live? not how do they want to die. And I think we spend a lot of time avoiding difficult conversations till people get in crisis, and then dump a lot of medical jargon on people in a crisis situation that implies that they have the power or control over whether their loved one lives or dies, which is a horrible thing to do to families. Because what it does is it displaces the responsibility from the people who are getting paid a lot of money and have a lot of education onto the family members who are in an emotionally traumatizing situation, when in fact, it is actually the physicians and the healthcare practitioners who should actually bear the responsibility to convey the appropriate information and to have the difficult conversations and not displace that guilt onto the family. So I was pretty passionate about having conversations with families and making sure that we had all the relevant information. How did this person live before? What did their quality of life look like? You know, why discrepancy between, I once had a man tell me he was independent, and for him that meant that he walked from St. Jacobs to Freeport Hospital and back every day just because he had nothing better to do. And similarly, someone else told me they were independent, and what that meant was they had to sleep in a lazy boy because they couldn't lie down because their congestive heart failure was so bad, and their maximum independence was shuffling to a bathroom 3 times a day with a walker. But if you asked both of those people and you asked both of their families, they would say, oh no, they were independent. You can see there's a pretty big margin between those two examples of what that means. So I think like we can go to the questions and answer more questions, but I think really the main crux of most of this question is not how do people want to die, but how do people want to live?
Thanks, Brenda. And that's what we do in our advanced care planning sessions. We try to focus on you're alive today. What do you want your life to look like? And yes, what your death looks like is extremely important too, but what is your best living days? So the 3 of you have really wrapped it up beautifully. Katie had mentioned about the families and how they coped. The families who had had good discussions, you knew that family, as soon as you walked in the room, you knew they had talked to their loved ones ahead of time and prepared themselves. You're never prepared to go through a crisis in your family. But there was night and day difference between the ones that had had open, honest conversations with their loved ones. And those families coped so much better with their loved one's illness. They didn't have the fear and the guilt and the horrors that the other families that had never talked to their loved ones went through. So let's move on to our questions. Susan is going to introduce our first question.
Thank you, Lynn. Each of your perspectives are really important because hopefully many of us will never go to an ICU or have a loved one in an ICU. But when we do, it's an unusual and alien place, as you've pointed out. Could you let each of you, from your perspective, let us know what's expected of an SDM when they're in the situation with you? And what do you personally feel are important criteria or could be helpful to someone who's choosing an SDM? I think any of you can speak, but maybe we'll start with Katie.
Sure. Yeah, thank you, Susan. So it's a big job. I think I kind of mentioned that when I first spoke. It's a very daunting task, and your role would be to hear all the medical information. The doctors are hopefully presenting in a way that anyone can understand, that you shouldn't have to have a medical degree to understand it, and digest that information, and based on what they're telling you, determine what's best for them. And unfortunately, the thinking is like, either do everything, but if I'm a vegetable, stop. And unfortunately, those two extremes are rarely what we do see. They're always in the middle, right? Well, we think we could maybe get them a bit better, but they'll never walk. They'll be in a wheelchair, but there's sort of this middle ground. And so you're the one having to tease that out. And sometimes that's a shared role, like if there's multiple substitute decision makers, and then you have to also get along with them. Hopefully those other people that are appointed are in the hierarchy you get along with and are all on the same page and have had the same conversations with those people. But I would say when you're choosing someone, it's good to think about, is that someone that I've had these conversations with, open, honest, you know, no holds barred, have that full conversation. Somebody that you feel can speak up in those moments. It's extremely distressing and hard to work through. So somebody that maybe in your life is a bit more emotionally fragile or not great with being, you know, making decisions, they're wishy-washy, maybe that's not the best person. Somebody with different, say maybe faith beliefs or moral beliefs that are different from yours. So some people may say, I feel that if I took someone off life support, that I am killing them. And if that's in keeping with what the patient believes, that's one thing. But if that's against what you believe, that's going to be difficult for that person, those beliefs to go against them. It's somebody that can say, despite what I think and what I want, because we often want our loved ones alive forever, what would my mom or my dad tell me to do right now? And that's what should be guiding you.
Thank you. Lisa.
Yeah, just to piggyback on what Katie is saying, having that person who knows what was important to you, and maybe what was important to you was to live at home until you die. And that often gets lost, even though I've heard so many people say that that is their goal, to be at home, to be functional until the moment that they die. And it's not until somebody's having that conversation from the healthcare team, and often Brenda or myself or other physios are actually saying, you know what, their function is not going to return to what it was before. And we can say that and help guide that person, that SDM or the POA, to make the decision, although it's going to be challenging. But if they were able to live at home until that very end, then maybe that's what it would have been important to them. So choosing that person who's going to be able to take in all the information. And as Katie said, it is overwhelming, all of that information at that time. Having somebody who is a strong advocate for you, who will be able to say what you would have wanted if you were able to voice at that time. And unfortunately, I've seen situations where, you know, a family member has elected a person in their family that is shares the same beliefs, but they're a bit more timid and they don't speak up. And unfortunately, the stronger one who doesn't share the same beliefs is the one who's saying, do everything. This is what we should do, even though it's not in keeping with what that patient would have wanted. And having somebody who's able to say that and feel good about saying that, you know, I've had these conversations with mom, dad, whoever, and this is clearly what they wanted. The team is telling us that they're not going to get back to walking to the store or to their friends the way they always wanted to be. Allowing us to take the brunt of, it's us telling you that you're not making that assumption on your own, that they would never get back to what they were before, and that person being able to take on that role and advocate for you on your behalf, even when it's a very difficult decision to be made. Thinking about who you're going to choose, hopefully you choose someone that you're very open and comfortable with sharing all of your information, your faith, your beliefs, and what is important to you. It has to be a discussion that's goes on continuously. It's not a one-time conversation. Things change over time. What's important to you in one moment may not be important in 2 years when you suddenly have grandchildren. My mother would say that she doesn't care if she can move her arms, legs, as long as she can watch her grandchildren play. Everybody has a different perspective. So having these conversations over and over is important when you're thinking about who you're going to choose to represent you if you're unable to speak for yourself.
Thank you, Lisa. It also, listening to you, gives me a perspective on how difficult your role is in listening to this and managing it. So it's helpful for us to understand that. Brenda, to you.
I always get the sum up blunt job. So I think there's a few key points. One is know your family dysfunction, because just because somebody loves you doesn't mean they're the best person to honor your wishes in the end. As a matter of fact, if you have multiple children and there's lots of dynamics and lots of unresolved guilts and lots of feelings about who's favorite or not favorite, in fact, naming your 3 children equally is probably a really bad idea. You really, really need somebody who has who who has the emotional objectivity to put aside their fear of grieving and do what you said you wanted done on your behalf. Because the job of an SDM or POA is not what they think you want, but it's actually what you would say if you were standing in that room while that decision was made. And that sometimes is a best friend. It's sometimes the neighbor who actually has provided care for 20 years and knows that person's actual real wishes and baseline. But just FYI, a neighbor can never be a substitute decision maker. If you know what your substitute decision maker hierarchy is, know that it's spouse or common law, depending on what that is. Know that the next level is living parents and all children together. So you can't pick or choose one. If you go by the substitute decision maker hierarchy, we have to honor that hierarchy regardless of how useful or useless one of your children is. We have to take them all equally, right? So if you have dynamics in your family that you cannot or feel should not go by the substitute decision makers hierarchy, you absolutely need a POA. You need to go to a lawyer, or you need to print off the forms, and you need to designate who is your decision maker, because we don't have any choice. If you show up in the hospital and you don't have a POA, we by law have to follow the substitute decision maker hierarchy. And nothing brings family dysfunction to the head quite like weddings and potential funerals. So if you have a loved one in hospital and you have any family dysfunction, we're going to find it pretty darn quick. That would be my best advice to you. Like, look at your family objectively. The child or the friend or the sister or whoever it is, who's the person who knows you and has the chutzpah to actually go up against everybody else to say, no, this is what this person wanted and we're going to honor their wishes, is the person you need to designate as your POA. And sometimes everybody's families are different. Only you know your own family and what that is. But if you're in a situation where they're having to honor your wishes around having a dignified death, I think probably the main goal should be that your family isn't left with unresolved guilt issues. That is your legacy to your family, because nobody really wants that. If you do, you got bigger family dysfunction, then probably we know how to deal with.
Thank you, Brenda, and thank you too for bringing up that substitute decision maker hierarchy, because a POA is what allows you to exactly specify who you want to be your substitute decision maker. We'll pass it over to Patty for the next question.
Can I
just Katie wanted to comment for a minute?
Can I just ask a quick, or just make another comment? I think another barrier we find is, how do we bring this up with our family, right? Whether it's asking our parents what they want or letting our kids know. It's still so taboo, right? We think if we bring it up, death is going to come sooner, or we think if you're asking someone what they want, they're wishing for your death. It's a very difficult conversation. And often when we're seeing our family, it's at happy times, birthdays, Christmas. And how do you bring that up over Christmas dinner, right? Pass the turkey, and this is what I want if I'm on life support, right? So I think this could be a great jumping off point to talk to those people and say, hey, I went to this seminar and this is what we were talking about. And they were really encouraging us to share what we wanted and ask other people what they want and make sure it's clear. So this is a good segue, having come to this presentation today.
Thanks, Katie.
You're welcome.
Patty.
Thanks very much. I'm going to twist the question that I was assigned, so be prepared. You all speak so well off the cuff. I'm not worried at all. I was to ask you about your use of terms like functional and cognitive decline and quality of life. What I'm hoping you can do is share some stories with us that would help more clearly define what that is from your perspective. Brenda did a little referencing the people who could and couldn't see themselves walking from St. Jacobs to, I'm not sure how many of all of us could do that, but it really helps to hear stories that you've experienced in the ICU when you're talking about quality of life, functional decline, cognitive decline. Help us have a better understanding of what is acceptable in terms of quality of life after ICU. You've given us some pretty blunt information initially. So let's do the rounds again. Okay, Katie, do you mind starting?
Sure. I think this is sort of more of a Lisa and Brenda question, but I can start. So quality of life, there is no clear answer, right? It's going to be different for everyone. You know, in the ICU, we would use the analogy. One person will say, if I can't do 18 holes of golf with the bag on my back, I don't want to be here, right? Which is to me extreme, but, and then on the other end, there's someone that would say, if I'm in a nursing home and I can't move, I'm dependent for all my care needs, I can't eat or talk, but as long as I can watch Sunday football, then I'm okay. So it's such a wide array, and no one else knows exactly what you want. I would say the best thing to do is, sometimes we think we have to know, would I want dialysis? What treatments you would want? And it's hard for lay people to plan that, because you're never in that exact scenario in the ICU, right? It's always going to be different. So what I would say is sit down and think, what provides me a quality of life right now? What do I enjoy in my life? Is food a big piece of it? If I had to have an artificial feeding tube in my stomach for the rest of my life, would that be okay? Is it being able to communicate? Some people love conversing and debating topics. And if they can't do that, you know, if their mind's not clear, they wouldn't want that. If they're dependent for any kind of physical care, personal care, a lot of people find that very undignified, and they would not tolerate that. So just really thinking through what brings you joy each day, and then from there can kind of determine what you wouldn't want, and then sharing that with your family.
Thanks
But I think,
very much.
yeah,
I'm
I
sorry,
think
Katie,
Lisa and
go
Brenda
ahead.
can.
Okay, Lisa?
I'm gonna
See,
let
Brenda, we're
go.
saving you for the end. You know that,
Oh,
right?
okay. Okay. I was gonna say, I'm happy for Brenda to go first if she would like to. We might have some of the same stories, but I'm sure we've seen many others in our day as well. But I can definitely go through a couple of stories. I mean, one that I can think of even just from last year was a gentleman came in to the ICU, had a stroke, and had a history of Parkinson's. And talking with the family, they, you know, weren't sure what they wanted to do. The team was talking about he already had a tube. So he had the tube through his mouth, and then he had been on it for a while. So the team is talking about putting in a tracheostomy tube, which is something that's a little more permanent, can be there forever, might be able to come out. And I honestly felt like the team was actually pressuring them to go forwards and to keep going. But I sat down and talked to the family and asked, you know, how well was he functioning at home? Well, really over the last little bit, he was not able to get out of the house. He was just walking around the house. He wasn't really always remembering, you know, just little things during the day, to turn off the stove after he's used it. And we had some great conversations of, you know, before he came in, whenever we sit down and talk about it, it's very clear that over the last few years, he's really been declining from his function. And I can tell them that after this stroke, on top of all of that, he's not moving his leg at the moment. Yes, he might get some return. And as Brenda said, we've worked with patients through the whole continuum. And after enough years of working here, I can feel more confident in what I think the outcome that he will have is. So we had a difficult conversation, and thank you to Susan for acknowledging that it is often hard from our perspective to have these conversations, because at the end of the day, I'm saying, you know, he's not going to come back home. He's not going to walk again, because his ability to retain the information, if he was already having trouble remembering things at home, it's going to put a really big challenge on him to be able to participate fully in therapy, to get back to that function that he was at before. And he most likely will not get home. And I'm fairly confident in that. However, I do always question myself, and I do always put myself in the other set of shoes, and always, you know, reflect back. The family decided he would not want to go through with this permanent form of ventilation that may or may not be permanent. He may have gotten off the vent. To be honest, I think he would have gotten off the vent, the breathing machine, but it wouldn't have changed where he went from the hospital. He would not go home. He likely would not have qualified for any rehab. He would have been a long-term care bound person, unfortunately. And the family decided, you know, comfort was actually the most important. And when I reflected back, because again, these conversations are hard and I don't love them, I will fully admit that, but I still felt good knowing that this person He wanted to live at home as long as he could. And the family expressed that. And this was his time, and he got to live at home until his time of death. But it's these conversations that they weren't able to bring that up right away, but when they were able to sit back and think about it and think about things he had said over the years, those conversations of I want to be at home and that's what's important to me, or with my family, with my wife, all these things that he would no longer have had, they really do come back and are very helpful. So I know that that's one story that's just a recent one, but I've had other gentlemen who ended up with flesh-eating disease and ended up with one leg amputation, and understanding that, you know, for him, riding a motorcycle was the most important thing in his life. Understanding that that was never going to happen again is something that changed his goals of care. He then would no longer want, you know, if my heart stopped naturally, then that's my time. I can't do what I wanted to do. And I'm already in this, I've already made it this far, but that doesn't change that I can't get back to who I wanted before. So if something does happen and my heart does stop naturally, then that is the time to let me go. And don't do CPR, don't do medications, whatever it may be. So I'm sure that I could list a ton of different patients, but those are a few that kind of, you know, stick with me over time. And I'm sure Brenda has a ton of.
Thanks, Lisa. Really, really poignant stories, and hearing them directly from you, I'm sure is very, very helpful to our participants today. So Brenda, like we say, we saved you till the last. As you said, you're the one that wraps it up.
I'm gonna actually not, because 32 years is a long time, and when I interview people, I always talk about your conflict patient. And every time I ask the question, I think, I don't know how I'd answer that, because it's actually hard with literally thousands and thousands of patient stories to jump one to the surface. So instead, I'm going to talk a little bit about categories or themes of things. I think one of the things people need to understand is what their actual true health status is, what their true functional status is, and what their true disease process is. So I'm going to say something that's a little controversial, because that's who I am. If you have dementia, you have a terminal disease process. Nobody tells you that when they diagnose you with dementia. As soon as you're diagnosed with dementia, if you don't die of some other disease process, you will eventually die of dementia. Dementia progresses to the point where you no longer recognize food, you have no drive to eat, and you will develop secondary complications related to that type of lack of cognitive ability to process. That is actually a terminal disease process. So when we do decision-making with people, except for young people, we've had some, Lisa and I and Katie could all rifle off some horrible, long-suffering tales of people who won't let their 30 or 40-year-olds die of advanced Guillain-Barré, advanced cancer, and keep them on life support for years, slowly whittling away. Because psychologically, it's very hard for parents to let their children go, even if it's in the best interest of their child. But in most cases, when we're talking about this, statistically speaking, it's a child making a decision about a parent. And often that parent had some degree of dementia underlying, including with cardiac disease and Parkinson's and some other type of situation. And the decision making I often find that's really difficult to navigate is people coming to terms with the fact that their loved one actually had significant cognitive impairment ahead of time that will drastically impact on their outcomes after survival if they survive. Because a lot of people in ICU develop ICU delirium. If you have a form of dementia, you're almost guaranteed to develop a delirium that almost never goes back to the same level as it was at before you were admitted to hospital. So you will get a step down decline markedly in cognitive status. That's almost 100% guaranteed going through ICU if you went into it with some degree of cognitive impairment. Contrary to popular belief, memory deficits are not inherent in aging. It's not a normal part of aging. If you're starting to have, if you are talking to your parents or a family member and they tell you the same story 5 times in the telephone conversation, they have some form of dementia. And it's time to get that checked out and figure that out, because people tend to show well when they're talking to their loved ones. What you're not seeing is probably worse when they're home alone by themselves. So that's actually a really important factor to consider, which I often have trouble navigating. So the way I often have the conversation with people is, what were they like 5 years ago at Christmas? Functionally, what was their conversation like? What could they do around the house? They were still golfing. They were still mowing the lawn. What were they doing a year ago at Christmas? What were they doing 6 months ago? And what were they doing right before they came to the hospital? Because everybody will tell you, oh, they were doing really great. But what they mean is, for an 88-year-old, we thought they were doing pretty good. But if you actually have the conversation about the trajectory of functionality and lay it down, now they've had a significant medical event. So they're not going to do this and then go like that. They're going to do, they were already doing this. Now you've added a significant medical event. They're going to go from here to here, right? And that actually has a really big impact on outcomes. And I often find talking about it in those terms to people is one of the most helpful things, because when they go back and start thinking about it, they realize, oh, crap, Dad was actually on a really steady decline that we just thought was aging, but actually means he's not as robust as we thought. And Katie will laugh at this, and Lisa, because we used to have a doctor who said, honest to God, I wish somebody come in and say they were a quitter. They never fought through anything in their life, because everybody comes to ICU and says, my loved one's a fighter. They're a fighter. I don't know what defines that, but when they get to ICU, everybody decides their family's a fighter. And the truth of the matter is, lots of us aren't fighters. Just because we made it to ICU doesn't suddenly make us a fighter. So that's what I would really say, is really look at specific functionality. Is either easy to look at. Physical functional deficits are easier to measure. It's the cognitive piece that often has the biggest impact on people's quality of life. And that is much more difficult for family members to get their head around, especially if they are from afar. And sorry if I offend anybody, but the well-known top 3 worst substitute decision makers are, son's a doctor and he lives across the continent and only has conversations on the telephone because he thinks he knows a lot, but he doesn't actually know what their functional status is. Any child is a nurse of any kind, or any child is a teacher. Those are the 3 most challenging substitute decision makers.
That's our whole team, Brenda.
I was going to say, Brenda, you nailed us all.
I know. Yeah, I don't know why, but that's, we all go, whenever we hear, oh, daughter's a teacher, crap.
And if I can just add something to what Brenda's saying, just in reference to like thinking mind over matter, they're a fighter. If they put their mind to it, they can do it. And I think sometimes we set up our loved ones for failure, because often, as the physios can attest to more than I can, it's not, if their muscles are wasted away to nothing because they've been in bed for weeks and weeks and weeks, or, you know, the nerves aren't firing, it doesn't matter if the physiotherapist is in there all day, every day, the muscles can't be built and the signals aren't going to their muscles to move. And so I do see a lot of it is, well, if the physio just did this, they would go to rehab, they would get home, but it really isn't that. It's the anatomy of the body. And I'm kind of stepping on your area of expertise, Brenda and Lisa, but it's not that. And then the patient feels like, okay, I got to just, you know, mentally get through this, but their body's not receiving those messages. One other quick thing I thought of is sometimes life support is seen as a treatment. It's something we do to make someone better, like an antibiotic or, you know, a surgery. It's actually something, it's a pause button in a potentially dying process. So someone's has something going on in their body, their body's dying essentially, and we put them on life support to press pause, to buy time to find out what's going on, what's happened, can we make them better? And oftentimes life support's a wonderful thing, but the other side is it can be difficult because we at one point have to hit play again. And sometimes that is recognizing that despite figuring it out or giving the medication, they weren't able to get better. So just so people know, the more you're on life support, it's not like every day, oh, they've had 5 days of life support, that's treatment. It's not, it's a pause button.
No, and actually it's worse than that. That's a really good point. People deteriorate daily in ICU. ICU is actually a very toxic environment to the body physiologically. So even if they tell you, oh, they're holding their own, they're actually getting worse every day. The average senior loses 3 to 5% of muscle strength with just bed rest daily. So this isn't intensive care where we pumped you full of all kinds of really neurotoxic drugs to keep you sedated so we can push air into your lungs without you freaking out, which also cause significantly more nerve and muscle loss than is normal just with regular bed rest. A elderly person just lying in bed without getting up and mobilizing loses 3 to 5% of muscle mass and strength a day. So you can imagine what a week of ICU does to somebody. So if they were marginal going into ICU, we gave them life support, which put pause on their dying process. 7 days later, they're going to be markedly in worse shape than they were the very first day we put them on life support. And that's something that people don't really understand. The trajectory of decline I talked about in functionality goes markedly down each day of intensive care.
Yeah, I appreciate you bringing that up, Katie, as well. It, as Brenda said, it is more than just lying in bed, and there is a whole huge medical picture that as physiotherapists that we are looking at whenever we're determining first of all, what treatment we can provide, but also what the likely outcome is, because it is not just about being in bed, and it is not just about participating in being able to participate in therapy treatment, but it is a whole variety of what is going on in your body at that time when you are that critically ill. Mm-hmm. And that often gets missed even in our team, not just with families, but in our team. And without us advocating, as Brenda said, we often see patients survive ICU to then have terrible quality of life, feel so angry, frustrated with what they are left with, if they are even able to regain the cognitive capacity to understand that. Mm-hmm. And that it's very challenging. Very challenging.
I can't tell you how much we appreciate the honesty and the forthrightness of your responses. We're getting messages through the chat already about people really appreciating how you are forcing this. I'm going to turn it over to Wanda, though, so that we make sure that we get through all the questions and we have time for questions from the group at the end. So Wanda, over to you.
Thanks. I've been working with the advanced care planning team for about 3 years now, and it's amazing to me how many of these questions come up in the presentations that we put on, but we have never had quite this degree of openness and clarity about some of these things. So first of all, thank you so much from me, and I'm sure the rest of the team, for helping us put this into perspective for people. And I see quite a few comments in the chat too about how good this is for people to hear these things and to put it into perspective in that you're not, excuse me, helping them keep breathing or not helping them keep breathing. There's so much else that's happening. I worked for about 35 years as a registered nurse. I worked in Owen Sound for 5 years on a general surgical floor, which gave me a huge perspective on all of these pieces as people came in, went to ICU, came back from, and the changes that happened for them. And then for a long time in childbirth, during which period of time we also had discussions about intubation, not intubation for babies as well, which is a whole different perspective, harder for people to talk about, but it's all of the same issues that we're looking at in terms of physical ability, mental stimulation, all those kinds of things. So this is really so good to hear your perspectives on this. I think you've answered my question already. I was supposed to ask you about CPR and DNR orders and the misunderstandings that there are about them. I think you've covered that really, really well already, but what do people need to know? Anything, if you could just touch on, each of you, maybe something that you haven't touched on already about those being part of the discussion, because we hear a lot about, should you do CPR, should you not, should you resuscitate And should I have a do not resuscitate order? And for me too, that's about what the circumstances are. If you're looking at, should we do resuscitation for this person or not? Where were they when something happened? All that kind of stuff. So there are a lot of facets to look at. So I'm going to ask Brenda to start maybe with is there another thing that people need to know about resuscitation that we haven't touched on yet?
So, because I'm the blunt speaker here, I'm going to tell you, resuscitation would be considered assault if it would be done on the street. So it's aggressive. It frequently breaks ribs. We put tubes in people, we poke holes in people, we do all, I say that it's not in my scope, that would be Lynn's scope. Physios aren't allowed to poke holes in people. We just give pain and suffering. We don't actually put holes in, they don't let us deal with sharp things or medications. I always say that. So I think that's an important thing to know. It is not a Hallmark movie. You do not have a pretty gown with a little tube sticking out the side and your hair looks good. People who go through resuscitation look ghastly. And often it's very traumatizing for loved ones to actually see their family members in intensive care. They don't actually recognize them because in order to stabilize them, we often have to pump them full of so much fluid to keep their blood pressure elevated that they can be up to 40 to 50 liters positive of fluid, which for those of you doing quick math can be up to 100 pounds of water just to keep somebody's blood pressure stabilized. It is a aggressive, invasive thing to be done to somebody. And if you're going to put somebody through that, you have to make sure that they're going to benefit out the back end of that. I think that's one of the things to really consider. The other thing I'll comment on, just so I don't forget, was because I actually was on the committee that was dealing with, in all the pandemic, I'm sure there was a lot of information about the critical care triaging that will be done across the province around who would get life support and who wouldn't get life support. So there was a lot of misinformation in the press about that. And what I can say is that what they used was objective measures that I think we should implement all the time. I actually think we should take the decision out of people's hands, the emotional decision out of people's hands and put it into the hands of science, which has some pretty good indicators of whether somebody would survive or not, having CPR. Some of those measures were actually functional measures. There was a pre-morbid functional skill set that indicated your level of disability and dependence. Because statistically, one of our ICU docs used to quote this all the time, if you are dependent for your care, your chance of surviving CPR is pretty close to zero. Very, very close to zero. It's not even statistically up to 1%. So I think that data should be shared, because if we're going to put people through this, they need to understand that their chance of not just surviving to a good quality of life, but actually just surviving at all is statistically extremely low.
Thanks very much, Brenda. Appreciate those comments. Lisa?
I think one thing that we haven't touched on a lot, I know the CPR and DNR orders, a lot of people get caught up on a DNR order thinking that we're not going to treat at all. And that's not what that means. And every treatment that there is, yes, we get consent for some, sometimes we just get blanket consent, but that doesn't mean that we're not going to do anything. And there's this misnomer that, oh, I'm DNR, so nobody's going to do anything if I suddenly I'm not doing well. That's not what that means. And that's not what we take it as a healthcare team. And there's so many treatment options out there for a lot of different things. And one thing that I just want to say that we often don't get presented very well, that comfort care is a treatment. So being offered, these are the treatments that you can have, but comfort is also one of the care treatments that we can provide. We can make your loved one or you comfortable if this feels right to you, that you don't want to proceed with these other treatments that we have offered. And that sometimes gets missed, but it should always be there as your options. The other quick thing is I know that our team does not always do a great job when we're talking about whether you would want to be on a breathing machine. Well, there's a big difference between being on a breathing machine for 5 days and living on one forever. And we don't do always a great job of, well, you know, I'm going to do it right now, but then we don't come back and talk about it in 5 days. Is this really something that they would have wanted to continue with? And I've been in very many frustrating meetings with our team where, you know, maybe it's a resident doing the conversation about we should do a tracheostomy because they've had the other tube in for too long, and that's just procedurally what we do. It's been in there for 2 weeks. Now we need to move on and think of a more permanent plan, because that's just not the right way that we do things. There's risk of it being, but we don't actually address, is that something that they really would have wanted? This is an invasive procedure. This is a surgery, and it's a more permanent thing. And maybe you only wanted to have that, maybe you want to have that shot of being on the breathing machine for a little bit, but then you can define when you think it might be time that, you know, I want to try it, but after 2 weeks, I'm just throwing out 2 weeks. After 2 weeks, if things aren't getting better, and even if they're getting slightly better, but they really haven't made significant improvement, maybe that's the time that I should be having comfort treatment instead. And those are discussions to also have, because sometimes we offer a treatment and then we forget to tell family that you can actually take away the treatment, or we can shift directions with the treatment.
How that's framed is important. You're not killing your loved one. They are already dying. They're on life support. We are, as Katie said, pausing, or I used to say all the time when I worked in ICU, I felt like I was the lint in the drain. They're still going down the drain. We're just slowing it down on the way. In a lot of ways, we're slowing it down in a way that doesn't improve their quality of life. And sometimes it's a fairly inhumane way of having them slowly pass away. So I think that's a really good point. Like, if you want your Hail Mary chance, have a blunt conversation about the time limit on that, because depending on the skill of the practitioner having the conversation, it may be presented in a way that makes your loved ones feel like they are making the decision to have you die, to take you off of this life support. That should never happen, but unfortunately I've observed that happen many times. And so whoever your decision maker is needs to know that if you want that Hail Mary attempt, that you know that each day in ICU is your chance of surviving markedly declines. And so there's a time frame, because just because you want to try life support doesn't mean you want to live on it forever. That's a really good point, Lisa.
Mm-hmm. Someone just in the chat said it's can sometimes be protracting death, like just slowing that process down. I think you both said it well. Like the DNR, do not resuscitate. I think that's a medical term used for the team to be able to quickly refer and say, okay, their heart has stopped. What are we doing? And they can quickly see those 3 letters and know what they're doing. But those letters have come into the public, and we hear them, and we hear, what do you hear? Do not. It's when anyone hears it, well, I want you to do everything for my loved one. And so what this shift has been in many hospitals around the world is saying A and D, which is allow a natural death. So I like to see it as, please do everything for my loved one here. But if their body is naturally dying and their heart stops despite everything you're doing, as Lisa said, let's shift to comfort, dignity, and respect. Because oftentimes when we quickly say, okay, do everything, put them on these machines, you're then left with making the decision, right? And not nature. So it's sort of a conundrum to be in, but allow a natural death, I think, is a nicer way to say it. I was thinking, I think we sound like we're being very negative and blunt and harsh, but at the same time, I realized we would be doing a disservice if we weren't, because so many people come into the ICU, and as Brenda said, they're kind of picturing what Hollywood would be like. And it's not that at all. It's a very difficult situation. It's something I wish on nobody to have to face that. But if you do, it's good to be armed with as much knowledge as you can going into it.
I think the three of us are both, we're all really passionate about the idea that in a dying process or an acute medical process, there's a lot of things you have no control over, but empowering yourself with knowledge about what you do have control over is really essential. because this is all about empowerment regarding knowledge, so that you can control the aspects that you can control. If you did not want to survive in a very debilitated state and be in long-term care, there are decisions that can be made that make the likelihood of that more or less, right? And I think you have to take control of the bit you actually can control, because we're all going to die. That's death and taxes, right? That's the two certainties. And so it's all about actually knowing what that trajectory potentially looks like for you and making decisions at specific markers that allow you to take back whatever control you can at those points.
I'd just like to say, Brenda, in response to your comment, all three of you are being very practical and blunt and to the point. But what I also hear from you is having respect for the person that you're the person who's there inside all of those machines and all the stuff that's going on. And that's what's really important, that you're respecting their wishes and you're just respecting them as a human being there. Thank you so much.
I was just gonna say, I would like to say that we all make decisions based on ethical principles that are sound, but I have to say, from a more cynical view, there's a lot of decisions made in healthcare that have to do with the discomfort or the avoidance of discomfort for the healthcare team, specifically the physicians. And whatever's easiest for them, whatever is their personal values, that is not what our ethics and values are supposed to be as healthcare practitioners. We are supposed to be seeking out and advocating for the values of the individual we are treating. But I want you to know that the reason we're so passionate about this is because all of us have encountered lots of situations where there were a lot of mitigating factors that had very little to do with empowering the person who was being treated.
We all leave at the end of our shift, or families leave at the end of their visit, and that loved one is still in that body, suffering, potentially suffering 24/7, right? And so the decision's hard to make, but at the end of the day, it's your loved one who's got to live that out and fight to get better potentially.
Okay, I cannot believe how fast this time went. Does that feel like it for the rest of you? Holy cow. This is an opportunity now. One point I want to make is I think we might have to change our advanced care planning education to take control, or take back control as the title, as opposed to, might be a little bit more forceful. And in that note, in terms of taking control, Patty and Wanda, does our audience have questions that they'd like to put forward?
Actually, there have been a couple of interesting ones in the chat. One was quoting some statistics about the number of seniors who live alone. 1 in 8 seniors live alone with no involvement of friends or family. So how do they choose a substitute decision maker? How would you, any suggestions from our team about how to handle that sort of thing?
I think it would be, I mean, yeah, if they don't have anyone, what would happen is my role as a social worker would be to try and track somebody down. So sometimes if, you know, maybe say you're a senior on your own, but you have a son that you no longer talk to, and he's kind of out there in the wings. If you don't appoint someone, that son, assuming he's your only child and you have no spouse, he automatically is your decision maker. So I do encourage you to create a power of attorney. How do you choose someone? That is tough. Maybe there's a close friend you trust, somebody at your church. Yeah,
it's the safest route to go is actually to go to a lawyer and designate a specific lawyer as your decision maker with a clear, with a clear, oh my God, the word just escaped me. This middle age is bad. Goals of care, or what's the word I'm looking for, Katie?
Directive.
Yeah. They used to be called something else when you went to a lawyer and you wrote down exactly what you wanted from a quality of life. Living will, right? Living will actually they don't have legal validity. That's but right. if you designate somebody like a lawyer to actually do it, they will execute your wishes. So if you're concerned, or if you have a super toxic, dysfunctional family and you're fearful, that's actually the easiest legal way of making sure you get what you want.
That's a good point, because if you don't have anybody, so there's no family and there's no power of attorney, we do have to go to the public guardian and trustee. and they're a stranger essentially, but that is their job, to come and hear from the team and try and make decisions on your behalf. And that's obviously not ideal because they don't know you. And what they're allowed to make decisions on are very limited. It's sort of continue on the ventilator or not. Can they go to a nursing home or not? There's very few things they can do. So yeah, I don't know if we're helping with the person who's doesn't have someone they can appoint, but maybe that's the solution, Brenda said, having a lawyer you know and trust can carry that out, as well as what to do. It's again, another blunt topic is when you pass, what happens with your remains? That's something also we struggle with, that nobody's there to claim your remains and ensure that you're laid to rest or your wishes are carried out. So it is important to find somebody to do all of that end of life wishes, advanced care planning, and then your death, funeral arrangements, that sort of thing is important as well.
I'm just going to quickly say that, as Brenda said, if you have some sort of friend or anybody like that you feel like you could appoint, but also just anybody you feel like you could have that conversation with and tell them what your goals are, all they need to do is to carry through with what you've told them. So it doesn't have to be somebody who's necessarily your best friend, just somebody that you trust would follow what you have said. And you can also write that out with your lawyer as well. And that person then knows this is what they've already said. And I'll just be the one to say yes or no to what's provided by the team.
So part of the challenge with writing it out, especially with the lawyers, they're moving more towards writing less in the power of attorney documents and asking you as an individual to write out what your wishes are, and following them to the letter becomes difficult if you haven't written enough down, gone beyond this treatment, not this treatment. That's where we come back to sharing your wishes and what good functioning looks like to an individual. I had a conversation with a lawyer not too long ago that was really upset that he'd taken on the role of being somebody's POA for personal care, because that relationship isn't enough necessarily to know the person well enough to make those decisions for them that go beyond the whatever's written down on the piece of paper. So I just caution people. In the US, they've gone towards appointing guardians through the court system, but that's run into challenges because of the potential for abuse in those situations. So I agree with all of you. There isn't a perfect answer to, if you don't have anybody who you can ask. That's a real challenge, and that question is really hard to answer. You have to go back to your own situation, try and find somebody.
I just saw a question come through. Can you hire a doctor to be your decision maker? The answer is no. A professional caregiver cannot accept money to make these kind of decisions on your behalf.
There's quite a few people. There's a few people who've had hands up for a while here.
Yeah, and we said we would finish the ones in the chat first. So there's one other that jumps out that we sometimes get to talk about, and that's how frequently should you be reviewing your wishes, because they change, and you've indicated that they change with circumstance, they change with accidents, they change with age. Any advice on that? And then I think we should go to the hands that are raised after that,
Okay.
Shelley.
I think Eileen would be the first.
Yeah.
Go ahead with the ladies. Do you want to answer that question?
I was just to say, any major change in status, like any major change in health status, any major change in living status, if you just sold your home and you moved to a retirement home, and that might change your perspective on things. If you've just been diagnosed with a disease process, you should be sitting down with your person and reviewing who, or if your loved one just had a major change, you should be sitting down and having a conversation about whether this has changed their perspective.
Yeah, or when your perspectives has changed, you know, you don't always know what you wouldn't want, and then say someone you know is diagnosed with ALS and they're wheelchair bound, and you think, oh, you know what, I changed my mind, I actually wouldn't want that, or if that ever happens to me, don't do that. So that when your thoughts are changing too, make sure you're updating your power of attorney, your advanced care plan.
Yeah, I think that just always having it in the back of your mind, what would be acceptable for you, would hopefully prompt you to when those discussions need to be had. Like I said before, you know, you might all of a sudden have a grandchild born, and then being able to just simply watch them is what is the most important to you in life. Or maybe if you aren't able to actually physically care for them, then that's the memory you want them to have of you, is you being there, being able to play with them. And then beyond that, that wouldn't be acceptable for you. So those sorts of things that are always be thinking about it, what's acceptable to you all the time, would be helpful.
I think in the concrete ways to deal with this, I often encourage people who have complex medical issues or diagnoses that are deteriorating, like let's say Parkinson's, to actually keep a functional journal. So because it's very much the frog in boiling water phenomenon. The decline happens slowly so that you're not going to realize you're in the boiling water till you're dead. The problem is that people don't have perspective on that. So I often encourage people to write a functional journal. How frequently, it doesn't really matter. Put a date, write the things you can do and the things you can't do, what you enjoy, what your struggles are. And at the front of that functional journal, put where your hard endpoints are. When my wife needs to wipe my bum because I can no longer make it to the bathroom, I no longer want to have a full DNR, or I don't want it. Like, make it, sounds bad, but like make it really concrete and functional. And that will be of great value to your family as well. That may change over time and you can modify it. But what it does is gives you concrete markers to say, this would never be acceptable to me. And so when you hit those markers, you can review and go, oh crap, I'm already in the unacceptable level. Is it still unacceptable, or is it time to review?
It's excellent, Brenda. Do you have
Thank
one,
you.
Brenda?
So I have the awkward situation of divorcing a few years ago and having 3 early 20s children,
Yeah.
one of whom would never take me off of life support. And I, as you can imagine, as frank as I've been, they've been raised with a very clear idea of quality of life. So I have reviewed, I have POA documents reviewing with them what I would or would not do,
Okay.
because they have because it would be more complicated for sure.
Okay. Thanks. Eileen, sorry.
Well,
to keep
I'll quickly give you a little backstory to tell you why I want to talk about how long you might want to be in ICU before you ask your family to withdraw attachment to life support. My spouse went into the emergency room, and it turned out he had something wrong with his kidney function, and they thought maybe he had kidney stones. And so at first they said, no, he could go home. And then they said, okay, you can stay. But he had eaten something in the emergency room. So 4 or 5 hours later, they could operate. He ends up going, being intubated on the bed. So he had no dramatic CPR or anything. And they intubated him, and he didn't come off for 15 days. And then you had to make that decision for the permanent trach and the feeding tube. It went on for like 40 days. And about the 30, and ironically, it was when the new ICU was being built in 2010, 2011.
Yeah.
So even if I wasn't aware of time, there were signs on the wall, 4 days till we get in. And one night, an emergency room doctor, because I was there, I took a leave of absence from work, and he said, do you think this was worth it? Because he looked at the chart and he saw me visiting. And I said, well, my spouse and I didn't have this conversation. So I said, this time it was worth it, because I did not know his wishes. Mm-hmm. Okay. So he survives, and he goes through, and he has that ICU hallucinations and
delirium. Yeah.
Yes. And a little change in personality. He goes to Freeport, he goes through this, and he lives to 2018. Mm-hmm. But somewhere in 2017 and 2018, he started to say, I want a DNR. I don't want to go through that again. So then we did the DNR, but he didn't want to tell the kids, which I found difficult. But now that I can express that, the difference between a DNR and still accepting treatment, because he did accept treatment almost another 9 or 10 months. So the only reason I told the story is that now when I wanted to leave my wishes, do I want to say, keep me in ICU or on life support for 40 days or 18 days? Like what, it changed my perspective when I would first say, well, don't, go 18 days, because if they can't figure out what's wrong and fix it, but he went 40 days and lived another 8 years. So yeah, even with these conversations and these reviews, it's a difficult thing to write down and be concrete about.
Yeah, it really It depends on what the system of disease and the issue is and all of that stuff, right? Like that actually really, really matters. It's not, for instance, we have lots of people come to ICU because it usually starts, well, we were drinking, and then they have a fight with their best friend and they break their jaw and they have to intubate them to do their surgery, right? That's a completely reversible thing that we just, they have a tube so that we can do the surgery, and then we pull the tube and they go back to their drinking with their best friend and
But
hopefully
the
don't break
issue
a
that
jaw.
happened with my spouse is when his dialysis failed, and he never really wanted it in the first place, but he did it. It was hard to tell the nephrologist why he didn't want a new line put in, you know, because his port didn't work and they were going to put in a line, and Dean was going to turn it down. The guy was in tears. But then I had to tell him the history is, my husband said, well, I don't want to be in the hospital that often because I have to come back 3 times a week, and look at my feet, you know, the color of my feet. So you'll fix this and I'll lose that. And he said, I've had enough. And
sounds like you were a great advocate, Eileen, for your husband.
Your case demonstrates, so one of the things that you point out that is excellent and we should mention is hemodialysis is life support. And so
we didn't really look at it that way. He was, I want to stay at home, but you're right, Shelley, my experience helps other people.
It's full organ failure, and without hemodialysis, you would die. So by the very definition, it's actually life support, but nephrologists never present it that way. And they never present it as an option that you can stop if your quality of life is unacceptable. And
I must also mention that I made sure he had no drugs, no sedatives or drugs, because he was in the dialysis unit. He's not a patient. You have to go through emergency to get. I don't want to take more time, but anyway.
So I think it's important that I appreciate your input, and this going back and forth helps us all. So thank you for sharing your story. But I know Liz has been waiting a bit here too, and we're getting short on time. So I'm going to turn it over to Liz.
I just want to congratulate you on a fabulous presentation. This has been so realistic, such an eye-opener, and I'm fortunate because I'm in the position where I have been able to discuss these issues with my 2 kids, my grown children. I'm 82, and I am looking at some potential fairly critical health issues, and so this is a great discussion. And I'm also have an appointment with my lawyer it was supposed to be Monday, and then that's a holiday, so it's postponed a week. And so this gives me items to discuss with her. But I noticed in the chat, someone else raised the question of MAID, M-A-I-D. And I wonder if that's something that could be addressed here, or if that's a topic for a different time.
Because MAID at this point in time isn't something you do as part of your advanced care planning process, Liz, we're going to leave it for today, but it's absolutely a conversation that we need to be having, but that one doesn't fit into the context of advanced care planning. So we're
okay. But it would fit into the context of an informed decision with your family, right? Yeah. So if that is something that you would value as something you would consider, it should be part of your care planning conversation with your family.
Yeah, and there are some lawyers. Oh, sorry, Lisa, go ahead.
Oh, no, I was just going to say that I think Katie would agree, because having those conversations with the advanced care planning as I've observed to be helpful with some of the families and patients in determining what they would like for their ongoing treatment. We've seen quite a bit of that, and it's been a wonderful thing to give people that option. After, sorry, Katie, go ahead.
Yeah, no worries. I was just going to say there are lawyers out there. I don't know, there's not many, but they are asking that when they're asking in people's advanced care planning, is MAID something you agree to? And I think if it is, you should be talking to your family, because that's often when people are in that scenario wanting it, one of their biggest struggles is, how do I tell my family I feel like I'm giving up on them, that they're not worth continuing to live, or maybe family members think it's suicide or assisted suicide, and there's lots and lots of issues to work through. So if that's something you feel you would want because a possible prolonged death is not acceptable, I encourage you to start planting those seeds with your loved ones. Hopefully
and I
never
think-
need to do it, but.
And I think the conversation was made at this point because the substitute decision maker can't make that decision for you is why you would want it. What
Yeah.
is it about your situation that they need to know that would make that your preferred choice? So it's not the treatment at the top, because MAID is a treatment. It's what's underlying that would make you want to make that choice. What do I need to know? Because I may not face that situation, but I may face another situation with similar.
I think that's a crucial point, is that the substitute decision maker can't pick it. The individual has to be of sound mind and pick it themselves. But the groundwork that your loved ones know you want this and you potentially are going to make the decision would make it easier for everybody if that wasn't a sudden decision that they were trying to grasp with, but if it was a well understood value support.
Shelley, Glennis has also had her hand up to
Okay.
ask a question. Can we go ahead with that one before we wrap up?
Yeah, go ahead, Glennis.
Thank you. Thank you, ladies. Thank you, Shelley and Patty, for pointing that out. First of all, I'd like to reiterate what Liz said, and this has been an excellent presentation. So thank you to the whole team here. Just a quick question about a practical question, I guess. A DNR has to be documented. So somebody who is a substitute decision maker, does that have to be documented? Do they have to present something in a document form, or is that something that can be relayed orally on the spur of the moment?
Yeah, it doesn't have to be written down. It's helpful to remind that person if they're making a decision for you, or say if family are challenging that, you can say, look, they've said this is what they want, but typically it is something that the doctors still have to bring up on every admission. So say you've written down that you don't want to be resuscitated, and a year from now you're admitted to hospital, the doctors do have to bring it up and almost put in an order into the computer. So it's good to have it written, but whether or not, as long as the substitute decision maker is saying, I know what their wishes were and this was their wish expressed to me, as long as it's an expressed wish, that's what we go by.
This actually raises a really important point that I think we need to talk about, is that the physicians will repeatedly ask this. As you change physicians, they all feel responsible that if they're going to write the order, they need to. So every time you come into hospital, the order actually has to be written. There has to be a DNR order on the chart, or they must do full measures. So if a physician hasn't asked the question and written the order, even if you have a prior wish on a previous encounter, they will resuscitate you. That's really important to know. And also, just because they continually ask you the question as a substitute decision maker doesn't mean that they're telling you you're doing the wrong thing. I once had a gentleman in ICU who had a long-standing living will, very explicit expressed wishes that he never wanted ICU care, and ended up in ICU. And when we finally extubated him, I said, hey, what happened? And he said, well, every day they came and asked me, do you want to be resuscitated? And I thought I must be making the wrong decision because doctors kept asking me. So I changed it. And I was like, wow, that's a valid point.
Yeah.
But it really has to do with the doctors need to feel like they're covering their butts from a legal perspective. And so they want to hear it themselves. So you will need to stand firm, and no matter how many times you're asked, reiterate what your actual wishes are. And it's not that you're wrong. That's not why they're re-asking you. It's because they actually have to write a new DNR order on the chart every time you're admitted. And every time you change process and get a new specialist, that specialist doing an intervention will probably ask you again.
And
We need to be better at doing that less, but some people also think, well, if I've been asked 3 times, it means that my diagnosis or my health issues are really serious. They think I'm going to die. And that's not the case. They think my heart's going to stop. It's not the case. They're, as Brenda said, obligated to ask and make sure it's clear, because in those situations when your heart stops, we don't have time at 3 a.m. to call your spouse and say, hey, we're just, this is what's going on. We need to know in advance so we can act immediately if and when that happens.
Okay.
And I Just wanted to say quickly with Brenda saying, you know, maybe, and Katie as well, we ask all the time, but I have to say that I've seen very terrible ways of asking, and then a second doc comes in and actually explains things appropriately, and then the answer is different. So I can understand why that, you know, docs, when they come on, have that conversation again. And to be honest, my dream would be to have an actual team who does this discussion with everybody when they come, so that we can actually paint a clear picture of what everything looks like and have that be an educated decision that everybody is making, because at times it is not well educated.
Right.
So I'm going to hold it there. And I just want to just make this one point though about the DNR. We're not talking about the DNRC form, although they are similar. For those of you out in the community, the DNRC form is the one you have with you. It's a consent form between you and your doctor, which is really about the paramedic, the you know, EMS coming to your door and having to know whether they resuscitate you in the house on their way to transporting you to a hospital or to long-term care or to hospice. So I just want to clarify, it's when you get to hospital, that process starts over again. That DNRC only gets you there. And then it's the same kind of conversation, but it's in the hospital. So I just want to say that, because we get a lot of questions about the DNRC, because typically our attendees are coming and they're living in the community right now. So I just wanted to clarify that piece. So we're at the end. I'm not going to launch my poll. I'll just send you the questions when I send you out the link. I don't know what to say. Like, this has been everybody said it already. This is excellent. To Katie and to Brenda and to Lisa. Wow. Yeah. You know, we were excited before. You did not disappoint. It was an amazing conversation. It's one that I've seen people say, and I'm going to say it too. We don't have this kind of conversation often enough or ever before. And I still have my notes from our conversation with you in 2018. So that tells you how valuable it was. So thank you very much. I don't know if the ACP team has anything they want to add before we close it off.
I'd like to jump in and thank our three guests for coming and joining us. Now you can see why I loved my job so much. I got to work with these three ladies every day. And
lucky you.
Oh, no kidding. The professionalism, the compassionate, heart-giving, they're just a marvelous team to work with. You could have written the book on our advanced care planning presentations, that you've covered every point exactly the way we wanted to see it covered.
And when and if you retire, you can join our team. We'd love to have you.
I've gone to the dark side and I work in management now, so.
We'll still take you.
Yeah.
Okay, on that note, I know it's the end of time, so thank you everyone for being here. And again, to our present presenters and to our team, thank you all for all you've contributed. And everybody's walking away with something to think about, so thank you.
Thank you.